I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island community. Today's program is about bone health, osteoporosis. What does it mean to you? We usually don't think about bones being healthy. We think about other organs of the body with their health and how we treat it. But if we lose bone tissue, bone mass, a lot of medical complications occur. Osteoporosis usually occurs in women. In the world, there are 200 million women with osteoporosis, and we'll talk about what that means. There are 9 million new fractures every year. That includes fractures of the hip, elbows, spine, all the parts of the body related to osteoporosis every single year. Is it curable? Is it treatable? My super wonderful guests, they did such a wonderful time. They were so wonderful the last time we had them back, is Dr. Philip Otterbeck, Chief of the Division of Endocrinology at Richmond University Medical Center. Thank you for coming.
Thank you.
And Dr. Lena Lakina, attending physician and endocrinologist and a fellow of the American
Association
of Clinical Endocrinologists. Welcome, welcome. She just had that new title, so it's a pleasure to see you both, and thank you for coming.
My pleasure.
What we're going to talk about is bone health. So let's talk about bones a little bit. We all have a lot of bones, a lot of mass, and sometimes we think of a bone as almost like a stone, that it really doesn't change. That's not really true. So before we even talk about osteoporosis a little bit, tell us a little bit about bones. Maybe Dr. Otterbeck.
So bones obviously form the skeleton of our body, and the bone is actually an organ system, and it actually changes over the course of our lives. There are different cells of the bone, osteoblasts and osteoclasts. The osteoblasts are the cells of the body that build up the bone, and the osteoclasts are the cells that break down the bone. And it's actually an interplay between these two types of cells that actually causes bone turnover and ultimately supports the health of our bone. And it is a process when we get osteoporosis, when there's an imbalance between what the osteoclasts and the osteoblasts do, that actually bone begins to deteriorate.
So Dr. Lakina, so it's actually, this is a living tissue. So the bone that you had when you were 6 years old is not the same bone when you're 20. Things turn over, it changes. So osteoblasts produce, osteoclasts break down, but basically the bone turns over. How active is this process? Because we don't think about our bones changing once we get to full size. We think about a child with a growth plate getting taller, or someone older, getting their bones getting thicker or thinner. But tell us a little bit about the bones themselves and how they all work.
Sure. Bones are actually very dynamic, and what's interesting about bones is that it is now considered an endocrine organ. It produces chemicals. There's a lot of metabolic processes that go on in the bone. And so there are these cells that Dr. Otterbeck described, and they are regulated by different substances such as hormones and outside substances. We now have medications that can affect these cells in different ways. So bones are actually, there are a lot of dynamic processes that occur in the bones. They certainly don't, on imaging, they certainly don't look the same when you compare an adult bone to a child's bone. But bone is always active, always making hormones and other substances, and it is a quite active organ.
So that's when someone breaks their bone, it heals.
That is correct, yes.
So then thank goodness for that, of course. So our topic tonight is osteoporosis, or thinning of bones. Porotic means things just become less dense. So tell us, who gets osteoporosis? Is there anything we could do to prevent it or cure the process? And is it curable or just treatable?
Yeah, so the osteoporosis, as you articulated, is a process of, quote, porous bones. And the formation of those pores results in the fragility, increased fragility over the course of a patient's life. Now, does everybody get osteoporosis? The answer is no. Some people are more susceptible for one reason or another. There's a genetic component, certainly, but also there are things that we do in our lives that result in the increased risk for developing osteoporosis. One of the biggest things that I see patients do, and I cringe every time I see it, is they smoke. Most of us achieve our peak bone age at age 30. Smoking is directly toxic to the bone. So if teenagers and people in their early 20s start smoking, what they do is they add that toxicity to their bone, the bone doesn't form properly, and they start off with a lower peak bone mass at age 30. And what happens, of course, with all of us is our bones deteriorate after age 30 over the rest of our lives. And if you're starting off with a lower peak bone mass, it increases dramatically the risk for developing osteoporosis.
So you lose your reserves somewhat.
That's correct.
Now, tell us about who gets osteoporosis or osteopenia. Actually, maybe let's go first with that. Give us some of the definitions. We hear a lot of different words. Osteoporosis, osteopenia, thin bones. Let's give us some of the real words.
Sure. So I usually tell patients to think about it this way. There is normal bone, there's an osteoporotic bone, and there's this gray area in the middle called osteopenia. I think it's easier to sort of put that in perspective like that for patients. We do have these devices, scanners, that measure the actual bone density to see how thin or thick the bones are. And so if these devices measure an abnormality that is consistent with osteoporosis, the patient gets that diagnosis. If it's measured somewhere in that gray area between normal and abnormal, it's called osteopenia, sort of a pre-osteoporosis condition. So that's how I like patients to
So there's
think
actually a
about these
scan.
things.
So since we don't want to expose people to a lot of X-rays, so this scan, and it's called a DEXA scan,
Right.
and it's a bone density scan we might have heard about. And with the bone density scan, isn't it more like how, compared to others, it's how many standard deviations you're off from being normal that determines it. So if you're off the curve, like that bell-shaped curve, that's where you make those definitions of osteoporosis, or if you're closer, just not over that line, I have osteopenia. So tell us, what's a DEXA scan? And we're at Richmond University Medical Center. Is it only is it only in the hospitals that have these scans? Do you have one in your offices on Staten Island? Are they all over the city? How commonplace are these bone density scanners?
The scanners are pretty common because it's recommended for patients to have their bone density scan at a certain age. So general population is screened for osteoporosis or osteopenia.
At what age?
In general, at age 65, but depending on their comorbidities, depending on other conditions they have, we may sometimes screen earlier. And so scanners are certainly available at Richmond University Medical Center, quite accessible. Other radiology offices also have the DEXA scanners. We currently don't have the scanner in our practice, but some practices in general do have, some endocrine practices do have DEXA scans. And so basically it's a low dose X-ray, so to speak. Patients are positioned on a table, and they take a couple of pictures of their bones and draw their conclusions in regards to the bone density based on that. Doctors get a score, and we interpret the score to be either osteoporosis or osteopenia. Sometimes it's not that straightforward. Sometimes it could be there could be a better score, but patients have more risk factors for fractures. So we tend to treat them, put them in that category as if they had osteoporosis.
So Dr. Otterbeck, if someone has osteoporosis, do they know it?
Well, they wouldn't know it unless they fracture. Because they don't feel osteoporosis. Osteoporosis is a silent disease. We talk about silent killers with hypertension, sometimes diabetes. This is also a silent disease. You don't feel it until you feel it, and that's usually when you fracture. One of the problems of osteoporosis is not only not feeling it, but it's also actually once you do feel it, that is, if you have a fracture, you don't get treated. In fact, 2 out of 10 people that have had a fracture, only 2 out of 10, actually get treatment to get a follow-up scan, which speaks to the fact that this is a problem that is under-recognized in the general population, both from a screening basis and even when a patient's fractured on a treatment basis. So it's important, and I think we've talked about this a little bit, is to prevent osteoporosis, prevent fractures, and the way of doing that is also to make sure we're consuming the right amount of food. calcium intake, vitamin D intake, getting our levels measured in our blood. And this is something that's very easily done just with a routine set of blood work in the doctor's office.
So we measure, so if someone comes into you as part of their regular workup, you'll do a vitamin D level, especially if they're at a certain age, to see if their vitamin D levels are normal. And so many of my patients have very low vitamin D levels.
Yes.
And I think it's a misnomer to think that if they're in the sun, they'll really get enough, but the numbers really show that very few people are in the therapeutic or even the normal range. Calcium in the blood we look at, and that helps us determine if there's some leaching out of the calcium from the bones. Are there any other blood tests that you look for?
With respect to blood tests, the most important ones are assessing the calcium level and probably the vitamin D level. But in some patients that have certain flags in their blood, we would worry about other disease states that could be causing the osteoporosis. Sometimes actually if the calcium level is high in the blood, those patients could have what we call a parathyroid problem. Sometimes the patients also have something called celiac disease, or problems with gluten processing. Those patients, for instance, they malabsorb their vitamin D, and you might have to give them very, very high doses of vitamin D to maintain the levels within the appropriate range. I always think of sort of the building blocks of bone as being the calcium and vitamin D. If we were missing the bricks and the cement, you can't appropriately build bone.
How about kidney disease? I mean, we have a lot of patients who are watching, a lot of people in the audience with kidney problems, and osteoporosis is more common in that population?
Yeah, so it's certainly true that it's more common in the population. What's complicated those patients and their disease states is that some of the drugs that we use to treat osteoporosis, we can't use when you have kidney disease. So when we see a patient that has kidney disease and osteoporosis, we have to see the degree to which they have that kidney disease and make our therapeutic selections based on the degree of renal failure that the patients have.
Why do women get osteoporosis more than men?
It's a great question. So as we all know, women at some point of their life go through menopause. What that means is that their ovaries make a bit less of estrogen and progesterone. Estrogen is considered to be protective for bone density. And so as estrogen levels naturally or physiologically go down, bone density starts to deteriorate. And that is a very important time to supplement with calcium and vitamin D, because that becomes a preventative measure for bone density loss.
Does estrogen replacement help patients with osteoporosis?
That's another great question. So estrogen replacement is not currently recommended for that purpose. However, we do know that estrogen is protective against loss of bone density. So there are certain instances where estrogen replacement is recommended for other reasons. And so in that case, it serves also its purpose protecting the bones. But not only that, these days it actually is a very interesting era in the world of osteoporosis, because we have many classes of medicines that we probably didn't have only 20 years ago. And so some of these medicines selectively stimulate estrogen receptors in the bones. What that means is that you don't get this overall estrogen effect on other organs. You only target the bones, which makes these drugs perfect for their purpose.
Do medicines like testosterone, we think about men with testosterone building up muscles, does testosterone help, or any other anabolic steroids, with regard to bone health?
So we wouldn't recommend testosterone therapy just for osteoporosis treatment. If a gentleman came to me and had osteoporosis, I certainly would measure the patient's testosterone and, of course, treat them appropriately if indeed it were low. However, there are other available therapies that will be recommended because of the potential side effects that would go with testosterone replacement therapy. Specifically, that's involving making the prostate too big, called a process called BPH, and also there's some association with prostate cancer. So we don't recommend it sort of as an upfront modality of therapy, but in a gentleman that has that particular problem, we would certainly supplement the testosterone.
So in patients who, as a neurologist, so many people come to me, and when I ask them, one of the first questions we ask, how tall are you? And the first thing they say, I used to be 6 feet tall. How tall are you now? Someone measured me, I'm 5'8", 5'9". A woman comes in, and maybe she's 5'5", and says, I used to be 5'7". When people shrink and they talk about getting shorter, is that osteoporosis?
Well, one of the advanced complications that we see of patients that have osteoporosis is fractures of the back. And classically, the typical picture of the patient that we see when we have in our minds of osteoporosis of these little old ladies with a cane all hunched over as a result of multiple fractures of the back that have kind of tipped that lady over the course of her life. We don't see that as much anymore. Why don't we see it as much anymore? Because we're certainly eating better. We are screening for osteoporosis. We're treating patients with osteoporosis to prevent the morbidity and, in fact, the mortality that goes along with that patient that has that osteoporosis to that degree.
Interesting. So now let's jump into therapies. I mean, we spent the first half of the show talking about what bones are and how dynamic they are, and that so many of us, women more than men, get this process largely. There are a number of treatments out there. So if someone comes to you and they went for that DEXA scan and that bone density scan, and they turned out to have osteoporosis, well, let's say, even with someone with osteopenia, what would you recommend? How would we start treatment? And let's jump into what the treatments are, because we've all heard about them, and so many people in our audience are worried about the side effects of the medicines, and we're going to start going over them, because I think that's important for everyone out there. So tell me, when do you start treatment?
Usually when the patients are screened for either due to reaching the age of 65 or having a fracture, the treatment starts as soon as the osteoporosis is diagnosed or right after fracture is repaired. And so at times, as we discussed before, some patients just fall into this gray zone, but they are considered high risk. And so there are certain scores we calculate to place them in that category. And those patients become also candidates for treatment to prevent fractures from occurring due to loss of bone density. So those patients are at risk, and they do have to be treated.
So, and Dr. Allan, so tell us what the medicines are.
So, the base of all osteoporosis treatment is first taking enough calcium and vitamin D. And for calcium, we would certainly recommend that patients take at least 1,200 milligrams of calcium per day in order to adequately build bone. Second thing is vitamin D dosed by level. So we would check vitamin D levels and ask them to escalate the dose of therapy depending upon what the level is. And generally speaking, we like that level to be greater than 30. Then, of course, comes the pharmacotherapy, the stuff that the patients come to us and ask us to prescribe, or we ask them to take. And there are different classes of medicines. The main class, the one that our go-to, our first class of drugs that we aim to give a patient is the bisphosphonates. And I know I talked a little bit about the bone physiology a little while ago. I'll just review that slightly for a moment here. Most of the place where these bisphosphonates work is at the level of the osteoclast. Essentially, the osteoclast takes up this medication, and it causes what we call apoptosis. The cell dies. When this osteoclasts die, it allows the osteoblast to come in and start building up the bone.
So you don't break down as much and you make more.
Exactly.
So give us some names. I mean, for the audience, at grand rounds at the hospital, we like to talk always in the form of generics.
Yes.
And that's also a rule at all academic centers.
Yeah.
But for us, make it for the people in the audience, they're taking these medicines, and they want to know what medicine they're taking and if it falls into that category.
Yeah.
What kinds of common names are those medicines?
So the name that we'll see a lot is Fosamax. The generic name of that is alendronate, and actually many of our patients are probably getting the generic now because it's off patent. Actonel is another one, Boniva is another one, Reclast is another one. These are all under the class of what we're calling bisphosphonates, and what I'm saying now applies to all of those drugs.
And they're given in different ways. So tell us some of the, does it have to be a pill? Could there be different mechanisms or intravenous? How do they get these medicines, or how do most people take them?
Yeah, so the most common one, the alendronate, the Fosamax, that's a once-weekly pill. And patients generally are asked to take that pill with a full glass of water on an empty stomach. The reason you take it with a full glass of water is you want to make sure it goes all the way down. You don't want to get stuck in the esophagus because it can cause some erosions of the esophagus and gives the patient some pain. So you take it with a full glass of water on an empty stomach, and that's really it, once a week. There are other pills that are once a month. And there is actually the intravenous preparation that's actually given once a year. So you had to come to the doctor's office, they put in an IV, the bag runs with the medicine, and then you're good for a full year.
Somewhat convenient. How do you decide which medicine to give to which patient?
It's a very complex process. Obviously, there are other comorbidities. We take that into consideration. Also, as you know, any medicine has usually a list of side effects, as I tell patients. So that also comes into play. And some patients just cannot keep up with this once weekly administration, and they honestly report that. They say, you know what, I mark it on the calendar, I do my best, but I forget. And so maybe for those particular patients, this once a week medicine may just not be ideal, even though it's a great medicine and it works very well for bones. So those patients may come in for injections or an infusion once yearly, and so on and so forth.
A lot of my patients are concerned about a side effect called jaw necrosis. And what a scary word, that there's necrosis is death of the tissue in your jaw. Is that something that is commonly seen with these medicines? There's a concern about it. How worried should they be? Is it a common side effect? I mean, everything has side effects, and we know, and we can't say that any medicine is immune to side effects. But how often do you see it as something that is the risk of these side effects more than the risk of osteoporosis in your patients?
Yeah, so what I always ask, and that's an excellent question, is I always ask people to think not only of the side effects of the drug, but also the side effects of not taking the drug. And certainly the risk of not taking osteoporosis drugs, the risk of fracture, the risk of mortality and morbidity that comes with this disease, the benefit of taking the medicine dramatically outweighs any particular risk to the patient with respect to osteonecrosis of the jaw. Of course, when you're that patient that gets that side effect, of course, it can be a dramatically inconvenient thing and a painful thing if you got osteonecrosis of the jaw, but nevertheless, it's a very, very infrequent side effect. In fact, Merck put out some data that it was a 0.7 cases out of 100,000 patient years. So a very, very rare side effect. I don't know that I've ever seen a case. I don't know, Dr. Lakina, if you have either. And these are drugs that we use all the time, and she and I together, in our experience, have not seen one case. So very, very unusual.
Okay, and that's important to know for our patients. And back to what I do, seeing so many people with back problems as a neurologist, the compression fracture issue is something that we see a lot of. We see people who have back pain who never knew that and what a compression fracture is, your vertebrae looks like a square. And it's not like it's not broken when you get a compression fracture. It becomes dented and it becomes smaller. And that area makes you shrink, as we said before. You lose height, you get the lack of flexibility, you get nerve injury because the nerves run right through that area. So having patients with compression fractures is a devastating thing. The other thing that we see so much is hip fractures. And patients over senior citizens over the age of 65 and even more over the older senior citizens greater than 85, having a hip fracture has a very high mortality rate within a year. So trying to prevent those things are so important. So if you go into your internist, and I have two wonderful specialists here. If you go into your internist and what should you in the back of your mind, most of the internists out here were marvelous on Staten Island and all of New York City. I've seen some of the best doctors around. If you're 65 years old, should you ask your doctor for a bone scan, for a bone density test if it hasn't been done? Should you be proactive with this? Tell us, because I always want our audience, who are the most wonderful people, and they write us all these wonderful notes and letters. Really, I want them to be on top of it. What should they tell their doctor? 50 years old, 60 years old, 70 years old. Who should ask their doctor, I need a bone density test?
I think patients need to be proactive in their health. We all do our best and we all try to be perfect, but sometimes things will slip our minds and we will miss the fact that patients coming in 65 years old, we make sure they had their, their breast exam, we make sure they had their colonoscopy, but you also need to make sure you have the bone density. So it's a great reminder for your clinician. I don't think anybody would be offended by receiving the proper information that, oh yeah, I'm due for my bone density examination.
And how often do you get it?
Well, you start at 65, as Dr. Lakina pointed out, for ladies, and there's some recommendations that men should start at age 70, and you would check it every 2 years.
Every 2 years.
Yeah, and that's whether you're screening or whether you're monitoring a response to pharmacotherapy.
We have a couple of minutes left,
yep.
And we started talking about estrogen replacement therapy, and to have two endocrinologists here is just such a treat. Tell us, there's such controversy about using estrogen replacement. What's the cutting edge issue right now? I mean, it helps certain bone issues, but we don't want to take it because of side effects. Maybe if you could give us a little bit of a background, a little bit about estrogen replacement therapy, the pros and the cons.
So I think when this has gone through phases in sort of the medical practice. I think that as women were entering menopause, certainly there are changes that go with menopause, and folks were thinking, well, estrogen has become low, therefore we should give estrogen. And then what we were doing is we were seeing some of the negative aspects of the estrogen, increased risk for clots and breast cancer and such. So then what doctors did was, well, they didn't want to cause their patients any harm, so they took it away from everybody. And then a lot of ladies, as they went into menopause, were getting a lot of the menopausal symptoms: severe hot flashes, severe anxiety, inability to sleep. And so at this point in our analysis, I think what most of us are doing is we're taking the patients patient by patient. And there's actually very strong evidence that when you initiate the estrogen at menopause, when the patient actually is experiencing the symptoms, they do not, generally speaking, have increased risk for heart problems and cancers and things. So the idea that I think we're focused on now is identifying the right patients for therapy, that is the ones that are symptomatic, giving them the therapy that they need, and not over-treating or under-treating the patients that were, getting the exact folks that need to be treated, we're giving them the therapy that's indicated.
And that's so important. As you said, this has just gone back and forth so much. Mm-hmm. There was actually a literature about it helping people to prevent Alzheimer's disease.
Yes.
That turned out to be false. There was actually a thought about it helping to prevent strokes. That turned out to be false. And we've gone back and forth on this for such a long period of time that it's wonderful to have experts here, but to really put yourself in their hands and try to figure out what side effects regarding being perimenopausal, makes you need to. Now we'll go over a little bit more of a controversial issue when we touched on it before, and that's anabolic steroids, testosterone. Yes. I mean, a lot of men use it to have big muscles. And when you see patients all the time, I'm sure they ask you about it. Tell our audience a little bit about it.
It's a great question, and I don't know how much time we have left, but in general, I want to say that testosterone, it is an anabolic hormone, and it is a prescription medicine, and so it is to be treated as such. A lot of patients view it as a supplement or something that would increase their muscle mass, which yes, it will, but it also is a medicine just like anything else, and it has a whole list of risks associated with it. So testosterone at times is absolutely necessary, but then there has to be an illness to necessitate that treatment. So I think that patients in general should not think of testosterone as a supplement. Testosterone has to be measured, tested. If it is found to be low, there has to be an illness diagnosed. And then when the diagnosis is made, then the treatment is offered.
So the way you diagnose it is through a blood test? Is there anything else that you look for? What symptoms would someone have?
So someone would have low libido, meaning low sex drive. A lot of men think that erectile function or lack of acceptable erectile function is due to low testosterone. It's not always the case. The most common symptom of low testosterone is actually low libido, low sex drive. They would also lose muscle mass as expected, have some sort of fatigue, generalized weakness, at times depression or depressed mood, and so on.
And are there any supplements that will replace it? I mean, I watch television, I go to the gym, and I see all these people taking all these different supplements. Does it help? Does that actually increase your testosterone?
It's not known to help. Testosterone is a hormone that's released into the bloodstream by testes or ovaries in females, and adrenal glands make a little bit, and so it has to be somehow accessible to the bloodstream. So either we prescribe it in a form of an injection or something that is topical in the form of a cream or gel. To date, there have been many attempts to make testosterone or testosterone stimulating products that patient can take in the form of a pill, which would make it very convenient for them. However, those attempts have miserably failed. There is an FDA-approved product for it, but it is not being widely used due to side effects.
We're going to wrap up. I want to say thank you to both of you. We had a wonderful conversation about bone health, steroids, hormones, and I want to say you've been such marvelous guests. We're going to have you back again real soon. Thanks again, and good night.
It's been a pleasure.